The next case is 50-year-old man with pancreatic duct stenosis. The patient has history of recurrent acute pancreatitis. CT scan shows main pancreatic duct stenosis. Scheduled for further workup with AUS and possible FNA. Dr. Stefan Seewald in the endoscopy room.
Yes, welcome. First, I would like to thank to be here again invited for the second Tokyo Live. It's a great honor for me, and it's not only an honor for me to be here, but also to present this case with Rob, because Rob is not only a pioneer of EOS, he is also the greatest teacher ever for EOS, and I'm very happy that I'm also here with my good friends Ryozawa and also Norio. So we have here a very interesting case, and we have to clarify several facts. As you have seen in the MRCP, this is a patient. He has a cystic lesion of the pancreas, and what we have seen already in the MRCP is that the pancreatic duct is very much dilated, more than 6 to 7 millimeters. This is the first point. Second point is this patient also has a stricture of the pancreatic duct in the area of the corpus tail. This is the second point. And the third point is patient also has a pancreas divisum. So in this case, before I performed the EOS examination, I used a regular duodenoscope, and I wanted to check the minor papilla in order to check if a patient has a fishmouth papilla. So we have found the minor papilla. The minor papilla is not very big. It had a little bit opening, but it was not such a nice fishmouth papilla we usually know. So this is the information. Patient has prominent minor papilla that fits to the pancreas divisum. It's a little bit open, so we suspect mucus. And now we want to try to show you now the pancreas here by linear EOS. Always we have to start a structured approach when we have to look at the pancreas, and I also always start in the area of the G junction. So we look for the celiac axis, and Norio has explained this previously. I follow the celiac axis, and then I look here for the takeoff of the hepatic artery and the splenic artery, and then I automatically somehow find the pancreas. And you will notice here already we don't have a huge pancreas like regularly. We see here already an atrophic pancreas, and now I use the flow. So we have identified here already the pancreatic duct. And first what we notice here is that the pancreas is relatively small in this area, and also here is somehow around this duct we see somehow echo-rich, somehow echo-poor area around the pancreatic duct. Okay, now we are somehow in the middle of the pancreas, and now we have two possibilities to observe the pancreas. We can talk the echo endoscope clockwise, and sometimes we have to retract a little bit the endoscope. So in this, when I do this, then I go more in the area of the pancreatic tail. And when I torque the scope counterclockwise, I will come in the direction of the pancreatic corpus, and I have to push the scope a little bit in. Okay, let's stay here now in this area. So what we have here, this is the pancreatic duct. I think we will measure it first. Maybe Norio will help me. Thank you very much. So for this area, this is a definitely dilated pancreatic duct, about 4.5 millimeters. And then we can also observe the atrophy of the pancreas, which is also somehow already a suspicious sign. And now, when I torque the scope clockwise, you notice that here in this area we experience a compression of the duct. So here really in this area there is a compression of the duct, and I think what we have noticed first, that there's something around the pancreas. There is something definitely suspicious, because I think this is somehow, I would describe it as a lesion, this area around the duct. What would you say, Rob?
Yeah, I think it's what I call a transition zone, where you've gone from a sort of a regular duct, an obvious duct, and now there's nothing there. So this is a very suspicious area. But what we were talking about also is that the duct is dilated downstream of this area. So it suggests that there is also something going on in the head of the pancreas or something downstream to produce both the atrophy as well as the dilation.
Yeah, exactly. So we have checked now
This is a bothersome area right
the tail area of the pancreas by torquing the scope clockwise, and now I torque the scope counterclockwise in order to see if we can trace the pancreatic duct into the area where the dilation starts. And here we have a little bit the problem because we have atrophy of the pancreas, so we don't see so much of the pancreatic tissue. And here I'm already in an area where I push the scope a little bit in, and now we see here the portal vein, and this is a very important image because we can only also see from the stomach, we can also see already the pancreatic head. And we see very nicely here below the portal vein area, we have here this area of the pancreatic head, and there we have a very suspicious cystic lesion. And I think the most important for us is now to get some more information and to describe more this cystic lesion. So what we notice here, this is not only one cyst, there are several septae, so this is a cystic tumor. We have to classify this. And then if we have a look at the septs, we notice that they are relatively echo-rich and they are also relatively thick. This is the first point of the septs, and when we have a look at the, maybe we freeze, wait a moment, let's freeze here. We notice very nicely on the bottom of the lesion, we have really typical nodules. And I think we should measure also these nodules. Wait a moment, okay. Yeah, and then, yeah, okay. So this is a very thick wall, 5 millimeters. So, and now the next point is, I also look if we can see any calcifications. So far, I don't see calcifications. I would describe that we have maybe echo-rich areas also in the septs, but no really calcifications. But I think this is a cystic lesion suspicious for malignancy because we have many features of malignancy. We have thick septs, we have nodules, and we have a thick wall.
Stefan, I cannot confirm the nodule. Can you confirm where is the nodule?
Okay. So I thought, a moment, the point is, I think we will later anyway have to. The point is now the lesion we can see here very nicely because the pancreas is so the pancreatic head we can see nicely from this area, but I think better later if we go to the to the duodenum and find the lesion again, because then it's more close. Yep. Okay, so for the orientation now, to get the structures of the pancreatic head, a further landmark is the apex of the duodenal bulb. And in this area, in order to find structures of the pancreas, for you it is important to try to find the portal vein. And I think here we see very nicely the portal vein, and we can also look for the bile duct now, because in this area, this is a typical area where we can find the bile duct, and then we can trace the bile duct into the direction of the liver or into the direction of the ampulla. And now let's try first now to find here this, the bile duct. So I torque the scope a little bit. So what we see here, this is, I'm not so sure. Try.
So he's in the apex of the duodenal bulb, or at least that general area. And from this position, normally you see the the
Okay.
portal vein
I think it's
sweeping
bile
down
ductus. What do you
from the left side of the screen down to the bottom of the screen, and then you look between the portal vein and the transducer, and that's the area where you will find the bile duct.
We will measure this. Okay. Yeah.
The bile duct should have some layers to it.
Yes. I'm not so sure.
Yeah,
And
this
I'm-
may be a cystic lesion in the pancreas.
Yeah.
I think,
Yes.
Because the abnormal structure
You're right.
there.
Yes.
It's quite irregular, so I would agree with Norio. That's probably part of that cystic area.
Yep, we see the portal vein
Not
here
sure
and
what
there.
that is.
Yeah, it's a
It's like an intramural cystic.
lesion.
We had this already today in the other case.
Yeah.
Okay, so what is not clear here, where is the bile duct, to be honest? Even
If the bile duct is very, very small, it can be quite difficult to pick up.
I talk now a little bit in this direction, yeah.
Yeah, maybe that's the bile duct there.
So now we are back, and we are now with the endoscope in the apex of the duodenal bulb. And what we want to show you now is this cystic tumor from the duodenum. So you see here very nicely that the lesion is now more close to the duodenal wall. And you see here, this is this cystic lesion. And we have observed this lesion now here. We would say these are several side branches, because when I talk the scope here and I move a little bit to the side, then we can see nicely here, there's the pancreatic duct, and we saw a nice connection to the duct here in this area. So you see here now in the middle the pancreatic duct, and we can trace this, and there is a connection to this cystic tumor, where we think this is a side branch IPMN with dilated side branches.
But we're also concerned about sort of thickening of the duct in this area. We haven't seen, I think we all agreed, we haven't seen a specific separate mass within this, but we feel that the tissue between the different cystic components, which is essentially the wall of the pancreatic ductal system, we think is thick.
Yeah, this is one point. The second point is, usually we want to nicely show the major papilla, but this is here very difficult in this case. We try to find the bile duct, which should help us to find the major papilla. We found the bile duct, but we cannot really trace it nicely to the major papilla, because the patient also has here such a cystic component. Here you see now the bile duct. Now I talk the scope clockwise, and I think here in this area somewhere there must be the major papilla. Another important thing what we can show you here is the pancreas divisum, because you see now here very nicely the pancreatic duct, and this pancreatic duct goes to the minor papilla. I pulled the scope a little bit out. Now I slipped out. I'm sorry. Wait a moment. We have it back here. Here you see, I would suggest here. Yes, here. Here in this area, I think here you see nicely the minor papilla. Here's the pancreatic duct, and then it goes to the right side, here, to the minor papilla. Okay, we discuss now what to do with this lesion if an EOS FNA is necessary. And I think now we see nicely the dorsal pancreatic duct from here.
That's a portal vein going through
Yeah,
left
that
to
is the
right.
portal vein. And
And just this GDA,
yes, and
or
down,
hepatic artery.
yes, down I think is this is here the pancreatic duct from direction corpus and tail. Okay, so I go back now to the stomach to check the pancreas again from there. Here. So here is again the area of the pancreatic tail and corpus. We see here this dilated pancreatic duct. And we always have the problem here.
Here's the
Yes.
duct, and it's this transition. Yeah, right
Right
there.
here.
We don't
Right.
see very well.
Yeah, that has been a problem that we couldn't really see this transition of the dilated.
Exactly. So, but I think everybody agrees that this cystic lesion is definitely suspicious because of the thickening of the septs and of the wall. Second, we have a dilated pancreatic duct dorsal to this lesion. So I suppose it's a clear sign of combination of side branch and main duct IPMN. And the third point is that we have also this suspicious stenotic area in the area of the pancreatic tail.
Dr. Seewald, we'll go to Dr. Saito's rectally.
So-
Okay, but
sorry,
we
Dr.
we can-
Toyonaga's is off
Can,
to
can
ESD.
we
We
just summarize the case?
Yes, please.
Exactly. So I think this is a patient who definitely needs surgery. We have a suspicious cystic lesion with thick septs. We have a dilated pancreatic duct. We have a history of pancreatitis. And we have a compression of the pancreatic duct here in the tail. So I suppose there is no need for performing EOS-FNA because we have enough signs for the further treatment strategy. This patient needs surgery.
And we think that if tissue was needed, at least in Japan, then maybe that is best done by ERCP and intraductal collection of fluid. If tissue is needed. But I think for all the reasons that Dr. Seewald mentioned, I think we're very, very concerned about this patient. And so I think surgical intervention should be strongly considered.
I think in this situation in Japan, it is very difficult to go straight to the surgeon. Before that, we need cytology,
tissue.
pancreatic cytology. So we need to insert ENPD tube and correct the cytology, pancreatic juice for cytology.
During the background, we're discussing it's going to be what type of surgery he's going to need.
Yeah.
So it can be.
Well, this is the problem because we've got disease in the tail and we've got disease in the head.
Right.
So you would look at a total pancreatectomy, which is obviously a
Morbid surgery.
a very, very morbid surgery.
Yeah.
I don't think he is diabetic. So if they're already diabetic, then that surgery is a less of an insult. But if they're not diabetic, a sudden total pancreatectomy can be very difficult. Yeah.
Yes. Okay.
Thank you very much for
Okay.
a very educational discussion.